to ask questions in the course of this clinical workshop. At the end, we will have opportunity to, for those who want to have that hands-on experience with live patients, who have that opportunity. So just stay behind and scan, all right? So the scanning machines are here. We'll have some surrogates who are pregnant come here to be scanned by you. Without any further ado, I'd like us to make welcome our presenter for today, our facilitator, Dr. Ifedi Okonkwo, for his presentation. Put your hands together for him. You can do better than that.
Good afternoon. The Director of Clinical Services and the distinguished colleagues of the Clinical Core of DIF Medical Center. You're welcome to this meeting today. As introduced, we're going to try and do a rough, down and dirty learning process of basic skills in ultrasound and OBGYN. As you understand, our hospital is primarily obstetrics gynecology emphasis. And therefore, if we master this, and I think if most of us who are involved in the care of patients concerned are able to master the use of ultrasound, we believe that that's going to go a long way in improving the service quality that we're delivering to our patients. The scope of this symposium is going to be, just like the title of the presentation says, Basic Skills in OBGYN Ultrasound. We will not be wasting a lot of time on the theory and the fundamentals of ultrasound, which has been adequately taken care of in the last meeting we had two weeks ago. Again, we're going to be quite basic, and we're not trying to make radiologists or radiographers out of ourselves today. We just want that fundamental understanding, which, in our opinion, is what we need. Each of us can then get to the next steps depending on their specialty, their unit, their professional requirements. And then we're talking about skills, not theories. In other words, just think of it as we're not trying to make engineers, we're trying to make technicians. So we don't need to know all the nitty-gritty involved in the whole theory and practice of ultrasound, just enough for us to, for every joint to be able to supply in this institution as we take care of patients that need ultrasound. Now, what are the prerequisites of, before you want to do a scan for a patient, an ultrasound scan, what needs to be there first? That's what I mean by these prerequisites. First of all, the machine needs to be understood and handled very well. Now, I think that was touched upon by the lecturer of the last meeting, but suffice it to say, you need to know that you need to have your machine properly taken care of. Otherwise, the practice of ultrasound, you get into trouble in this place. The machines are expensive, we've been told about that, so they need to be carefully maintained, they need to be handled properly, they need to be they need to be made to not be agents of transmission of disease from patient to patient or from staff to patients. Now, also, before you set about to scan a patient, your ability to perform ultrasound exam is highly related to your ability to understand anatomy and embryology. Now, anatomy in general, and embryology in the case of a pregnant patient that we're doing an ultrasound for. But for non-pregnant, so we're talking about a woman's anatomy of their pelvis. So if you do not understand properly how the organs and systems that are related physically in space, then your ability to perform a scan is already compromised. So it's assumed that we know these things to a basic extent. And then finally, you need to know the patient that you're dealing with. And that's what I mean by history and physical examination. It doesn't make a lot of sense for a patient to walk into the room and say, "Good morning, madam," lie down, and you start scanning them. So quite often, it sounds like it's an exaggeration, but quite often that has happened.
Patient comes in, says, "I'm having pain, I'm having whatever it is, I'm going to scan." And I think it's a shabby history. The already long I carry the scan prove and start trying to scan that patient. I need to understand the history. And I need to also examine that. For instance, there are signs I can see in the examination that will guide what you need to do in the ultrasound. How you need to approach that ultrasound. For instance, the route you take to the scan. And whether you even need the ultrasound in the first place, maybe something else you need first. Or something to guide you so that you understand what you're seeing on the ultrasound. So that, these things they go without saying, but I just thought I should incite them before we delve deeper. Indications for guiding ultrasound. When should you do, who should you do a scan with? There are traditionally in medical practice, there are reasons why you should do any intervention, even if it's an investigative intervention such as ultrasound. In other words, if there's no value in what you're doing, then you need to do it. So you must have and in the standard situation, you must have reasons for doing your scan because it's going to add value to your ability to make the diagnosis. Now, I have a list of conditions on the screen, and you can add a lot of other things to it. In this medical center, something that makes us stand out, which might be looked at a plus, as a plus or a minus, is that we perform ultrasound almost as an extension of our physical exam. So we don't always think of it that does this person need a scan, or will the scan add to my diagnosis or my ability to make a proper assessment of the patient at this time. And someone can argue one side or the other about it. But just to say that there are certain conditions, some of these things on this screen now, for which the scan is fundamentally important. In today's 21st century practice, without a scan, we're not going to be able to adequately take care of patients like this. And apart from gynecology, in the first trimester of pregnancy, there are still a number of conditions, beginning with diagnosing that the person is pregnant, telling where the pregnancy is located, and telling how old the pregnancy is, and what is the number of fetuses, and whether there are any pathologies consistent with that pregnancy. These are situations where ultrasound can help us make a proper diagnosis. Much later on in pregnancy, ultrasound is so critical for a number of conditions. For instance, for making a diagnosis, is the baby normal? Is the baby growing well? Is the baby lying well? Presenting which part of the cephalon, the bridge? Placenta healthy? Is it located, placenta located high or low in the uterus? Is the amniotic fluid adequate? What is the cause of the bleeding you might be seeing? Is the baby's heartbeat okay? what is the gender, maybe of babies. Now, these things are taken for granted, but these are some reasons why we do a scan. And what we need to do a scan. At the Duke Medical Center, a lot of our
procedures are guided by ultrasound. Of course, within the confines of the assisted reproductive team unit, it's taken for granted that almost every step of the care of patients involves an ultrasound, because that's what you use to look in and to assess the uterus, to assess the ovaries, to assess the cervix, take care of anything else that you need to do, to see how your treatment is being responded to by the patient at whatever stage.
Okay. And then guide procedures such as egg retrieval, membrane transfer, and so on and so forth. Outside the ART units, we also use ultrasound guidance and procedures such as cervical cyclage, amniocentesis, or individual sampling, and so forth. All right. Now, my current slide says examination etiquette. Now, if you don't, I think this is one of the often overlooked aspects of how we deliver care to patients. Now, when we want to perform a scan, ask yourself, am I behaving the best
way recommended possible to these patients, the patient's staff, to the patient's spouse, or whoever family member might be there? Am I portraying myself as a professional person? Am I conscious to the patient's need? So the patient is not a piece of wood or furniture. And the patient is a human. And the best way to put this in perspective is to put yourself in the patient's position. I don't know how many of us have ever had a scan done on them, or even an examination performed on them by a doctor or by a nurse or a medical team. How does it feel? So, before proceeding with ultrasound exam, make sure that the patient understands that they're going to have a scan, and they understand that they need it, and that they've given the consent. So even before you say good morning to the patient, you should obtain their consent, right? So we understand that because especially before you perform a scan, the patient has to perform a certain amount of exposure of themselves, even if it's just for that reason. I know that we take it for granted most of the time. For patients that have been in the system and that we are used to seeing, maybe because we think they're used to the ultrasound scan. So a patient walks in, says, "Madam, lie down." And you carry the probe and you I think it will help to sometimes remember that each patient is a person. So that politeness of explaining, so now we need to do a scan now. Are you ready?
Very, very important. Once in a blue moon, some patients have actually turned down the scan. But let's not head there. The other thing is to check the environment where you're doing the scan of patients. Gynecology scans sometimes, a lot of the time, invade the privacy of patients. So check that the door is locked, that the lights are very bright. I think it's very uncomfortable for the patients to expose themselves to a scan, even if it's an abdominal scan. It's also important because it helps your screen, the ability of screen clearly. So you can have an advantage as the person scanning your screen. The display screen is better. The lights are not that bright. So you get an advantage out of it. Again, be careful about transmitting infection from patient to patient, especially with the transvaginal scan, because vaginal scan actually invades. Vaginal scan is supposed to be a sterile procedure. Sometimes, at least, to make it a perfectly sterile procedure, make it a clean procedure. So the idea that our hands need to be clean and sanitized or washed before you proceed. And so don't take it for granted and don't gloss over it. And when you finish, how do you clean up your hands and your clothes? Because we know sometimes even body fluids are left behind in the clothes between one patient and the other. That shouldn't be. We need to take care of these things to make sure that we don't cause more problems that we're out solve for the patient. Again, be aware of the temperature of the room and the temperature of the gel, and try to protect the patient's clothing from the gel. The scan gel is not harmful, but it can be really very uncomfortable if the patient comes after leaving your room. They are going out with a patch of liquid on their clothing and visible outsiders. Alright, so when you place your hand on the patient and begin to scan, please be measured in your pressure. The patient may have pain. Maybe that was how we're scanning. So as that is going on, how much pressure are you applying? If they didn't have pain, some aspects of the patient's body might be more painful than others, naturally, even without an inflammation. For instance, around the umbilicus, the pregnant woman can be more sensitive than other areas. And for vaginal scanning, naturally it needs to be very measured. So do not apply more pressure than you need to. And it helps if you are communicating with the patient and telling them what you're doing and finding out how painful it is. Are you okay? Are you okay? Are you okay? Are you sure you're alright? Even when a patient who is heavily pregnant in the second half of pregnancy is lying on their back for a long time, sometimes just by lying on their back for a long time while they're scanning, they get uncomfortable, they get dizzy. So be sensitive to these things. Work efficiently. So while scanning, try not to be distracted by, try not to take too much time, as much time as necessary. Because if you're distracted by other things while you're doing that, you're making the patient uncomfortable. For instance, a phone call, text message, chats, gist, banter. When the patient is there, it makes them feel really, someone help me with English. How do you feel? Dignity is diminished, isn't it? Nobody's helping me. I don't know what kind of audience I have. Alright. Now, we said before, keep communicating with the patient. So the patient needs to be told not just everything is going to be okay, but about to do a vaginal scan now. It's not pain.
Have you had a vaginal scan before? If the
The
person
person hasn't had a vaginal scan before, you need to reassure them it's not pain and we're going to be as gentle as possible. And communicate what you're finding on the scan. You should, unless there's a strong reason why you should communicate what you're finding on the scan. Communicate. That helps patients understand what the matter is or what the matter is not while you're doing the scan. Because we are clinicians, we are not radiographers. We send a scan, the patient through a scan, there's a glass wall between the radiographer and the patient or radiologist. They just write and say, go back to your doctor. That's not exactly how we practice here. So there's a difference. Finally, for the patient's comfort, it might be important to have a chaperone in the room. Carefully, I think this matter has been dealt several times during discussions on medical ethics. The importance of making sure that you don't end up at the end of the scan what you did becomes described as something else is said that you did something else, when you did something else. That is very important to be conscious of. I understand it won't always be possible, but that is the ideal thing to aim for. Alright, now, for gynae and obstetric ultrasound, we generally we're dealing with pelvis. Obstetric and gynecology is heavily dealing with pelvis. Of course, sometimes things that are in the pelvis, they shoot up into the general abdominal cavity. So the process of scanning our patient's pelvis, we can't always run away from scanning up into the abdomen. For pelvic scans,
you either scanning from the abdomen above or you're scanning from the vagina below. Sometimes the decision for this is not straightforward. Now, but there's a general rule of thumbs. Now, if you are the patient and they want to scan you and they say choose where they want to scan you from, pelvis or abdomen, what's the choice? What's the choice? Naturally, I think I would choose abdomen. I don't want to be scanned from the vagina. I want to be scanned from the abdomen. And that's anytime a patient can be scanned via the abdomen, please scan from the abdomen. Only do a TVS when the TVS is going to add information that is not available to you from the abdomen, and that information is important. I think that is, we all agree with that. I'm saying that because a lot of the time, when we want to say I want to do a scan, I want to do a transvaginal scan. Okay, we did a TVS and we found, and we didn't even try an abdominal scan. Now, sometimes you assume that, okay, I won't find anything from the abdomen because I want it clearer, so let me go from the vagina. That's fair enough. If we don't need that much clarity, scan from the abdomen. I think I'm making that point very clear now. Even in a gynae situation or early pregnancy where normally you need a vaginal scan to make it clear, sometimes you don't need to do that. For instance, and there are situations where you can actually do a vaginal scan and end in error. For instance, the uterus is big, maybe with fibroids or adenomyosis or some other pelvic mass, maybe it's an ovarian mass below, and it's pushing the uterus upwards. And it is, for instance, early pregnancy. A small sac is in the uterus, but it's at the fundus, which is a normal place. And it's just 5 weeks, just 6 weeks, and you stick your probe from the vagina, and you might not see anything. Or you might think you are seeing the entire uterus, but there's actually a sac high up, which you didn't see. So, to get the best of both worlds, if you have enough time, and you want to do a vaginal scan, consider first doing an abdominal scan. Just see generally. Sometimes you see that certain things are even up there in the abdomen before you go down to do the vaginal scan. I hope it's understood. I hope you all agree with that. All right, so transabdominal, transvaginal, but there's also situations where you really need to look from below. But for instance, you don't want to put a probe in the vagina. For instance, the patient is Virgo intacta. The patient says, nothing has ever entered this vagina in my life. Or for instance, we have a situation where a patient is suspected of having dilated cervix in pregnancy, bulging membrane, or cervical incompetence, or low-lying placenta with the risk of bleeding. But you need to look from below. So you want to do a TVS, but you don't want to go and provoke problems. So sometimes just over the perineum can give you a view. So that's transperineal ultrasound. And a lot of the time, the normal vaginal transducer can do the job. So you don't always need to go in to see things, especially in critical situations. Sometimes what you need is to see, you're able to see what you need just pushing that probe against the perineum between the vagina and the anus. All right, so next now we're going to go through, first of all, quickly, basic gynae ultrasound. Then we'll rush through basic first trimester ultrasound. Then we'll rush through second and third trimester ultrasound together. So three groups of discussions we're going to have now. First of all, gynae ultrasound. What are we looking at? Now, this includes whether it's transvaginal or transabdominal. It doesn't matter. We're looking at the very same structures. And all the structures that you're seeing on the screen can be assessed from both sides, from the abdomen or from the vagina. In the case of the ovaries, it's a lot more difficult to see it clearly from the abdomen. So sometimes we assume you cannot see ovaries from the abdomen, you need to do a TVS. But it's not all the time that is. So sometimes you can, even with a normal ovary, see very well with a full bladder from the abdomen. So first of all, on the screen we have two images. On the left we have the uterus, on the right we have ovary. These pictures are from a transvaginal scan. So the structures of interest in the ovary when we're doing a scan, hopefully we're going to have a video which we had recorded a few days ago that demonstrates how these sort of images were captured during the scan. So we're looking at the uterus, the size of it, the shape of it, the regularity of the outline, and then the uniformity of the structure. And then we're looking at the endometrium. We're looking at the outside the uterus. We're looking on both sides at the ovaries. We're looking for ovaries. Normal ovaries should be visible in young women. And what makes you catch that should be ovary, is those black holes in the ovary that we call follicles. Without them, it can be quite easy to catch, quite difficult to catch. And that's why it's difficult later on in life when it gets reduced in size and there are not so many follicles in the ovaries. We don't look for fallopian tube on ultrasound. Normally, a fallopian tube, if it is healthy, you can't see it properly with a scan. And so we don't bother. But one of the things that you can see that you think is an ovarian cyst can turn out to be a fallopian tube, which means that fallopian tube is abnormal. It's got liquid in it. That's hydrosalpinx. So normal tubes, you're not looking for them in a normal ultrasound. Outside these structures, the spaces around the uterus, anterior to the uterus and posterior to the uterus, call it the pouch of Douglas or called the sac. That place is a very dependent place. Fluid tends to settle there. And in different situations, you might have fluid behind the uterus. You can see that either from the abdomen or from the vagina. What does this mean? Maybe it's beyond the scope of this lesson. We're not here to, learn pathology, but to learn how the normal is, so that at least when things don't look normal, we can then escalate the care and decide what next to do, or who next should help to make a diagnosis of what the problem might be. Now, quickly to the first trimester of pregnancy. First trimester ultrasound it's a foundation. It's one of the pillars of modern obstetric practice. It's important. It has made a lot of difference over the years compared to what obtained before. If a patient is pregnant, first of all, to confirm that pregnancy is something that we use ultrasound to do, apart from a pregnancy test. To localize it, which means where is it located. Determine the viability, which means is the fetus or is the embryo alive or not. And then to date the pregnancy, which means what's the age of that pregnancy. Then what's the number of embryos or number of babies in that pregnancy. So these are the main things we are looking for in a normal first trimester ultrasound. So, of course, is there any departure from these things? Then that's abnormality, which is the next level, and that's what we'll waste a lot of time today talking about. So first of all, for confirmation of pregnancy, the first sign that there is pregnancy is a gestational sac. Now that gestational sac is a ball of fluid, and I nearly said a gestational sac is a ball of fluid in the uterus. But because a gestational sac can also be outside the uterus, it's all part of what we're scanning for in early pregnancy. So it's important to diagnose a pregnancy early with a scan, because sometimes later on we're wondering how old is really this pregnancy. So the first thing you see is a sac, which appears about 4 weeks, very tiny. By 5 weeks, you might be able to see a yolk sac. By 6 weeks, you should be able to see a fetal heart, especially via the vagina, because it's closer. The vaginal root sees things 1 week earlier than abdominal root. Now, when you see a sac, you begin to check the appearance of it. A normal sac is round. It's not irregular in shape. Sometimes you see irregular shape and we're wondering, is this normal or not? And it's also located higher in the uterus rather than lower. When you have a sac lower in the uterus, it suggests there might be something wrong with that pregnancy, or it's a bad prognostic sign. All right. So then heartbeat, yolk sac appears first before about 5 weeks before the heartbeat appears to the naked eye. And that is, I don't think it's available on my slide now. All right. So that is about confirmation of pregnancy. If it's a gestational sac, I'm going back now, it has this double ring appearance. There are things that look like gestational sac. And if it doesn't have this double ring appearance, be careful. If it doesn't contain anything inside it, it might still be a gestational sac. So be careful. Sometimes there are cysts or collections of fluid in the uterus. That's sometimes called pseudo-sac. It can look like a sac and deceive the person that's not careful. Again, localization. Is it in the uterus? Sometimes it's difficult to tell. In this picture, you have uterus above, you have the sac below. The sac is actually below and to one side of the uterus. So this is an example of an ectopic gestation, which ultrasound is useful. This one is an abdominal scan that's used to take this picture. Now, is the baby alive? You tell that the baby is alive when you see the heartbeat. So if the patient is too early in pregnancy, you might not be able to see a heartbeat. Okay, so you're not seeing a heartbeat, maybe because it's not there, or maybe because it's not yet there. So in early pregnancy, we see a patient, see a sac, you don't see a heartbeat, we put a lot of things together. So you are supposed to be so age, and I'm seeing a heartbeat, or I'm not seeing a heartbeat, put it all together and decide, could it be that there's a problem or not? If you don't have a heartbeat, the baby is not alive. When in doubt, give 1 or 2 weeks and repeat the scan. Don't be deceived by the reported gestational age. Patient can say my LMP is whatever, and you calculate it, get 10 weeks, and you're doing a scan, and there's no heartbeat, but you're seeing a sac. Maybe they're not really 10 weeks. So we all know that these things can be wrong. Therefore, don't say it's a problem until you have made sure of it. When in doubt, repeat a week or 2 later. For dating purposes, dating means we look at a pregnancy, take measurements, and based on those measurements, the computer, which has a database of how many weeks old a pregnancy should be when it's so size. So the computer gives us an age. So like we've already said, the first thing we see is a sac. And at that time, you might want to have an idea of how old the pregnancy is. So we can measure the dimensions of a gestational sac, usually in 3 dimensions, and then get the average, and then cross-check. At so millimeters, what should be the gestational age? In this day and age, you don't have to do that calculation manually because each scan machine should be able to compute and give us an answer. So the images we have are showing us how we do that gestational sac. After 6 weeks, or from 7 weeks, between 7 and 10, it should not be necessary to do a gestational sac measurement, unless maybe the sac is empty, which is already pointing to a problem. We should measure the fetus instead. And the embryo in the first trimester, usually we can tell this is the head and this is the bottom, or this is the head and this is the rest of the body. So upper pole, lower pole, the crown and the rump. So we call the crown rump length. That measurement is what we have that at the bottom of that screen. It is the most accurate way of determining how old a pregnancy is. And the whole idea of a dating scan, a reliable dating scan, is based on a crown rump length measurement done between 7 and 10 weeks of pregnancy. Why not before? Because the image might not be clear enough to get a reliable picture. Why not after? Because as the baby gets bigger and is able to flex and extend, variability comes into these measurements. And generally speaking, as baby gets older, and it gets variability in normal sizes of patients or babies start coming in. So you might take measurements that says the patient is older. Now, the baby is actually bigger. Or it says that the baby is smaller in gestational age, but the problem is that the baby is actually small for age. All right. The other thing is multiplicity of pregnancy. How many babies are there? Is it twins, triplets? On this image, you can see an example of a pregnancy with 2 sacs, but 3 embryos or 3 fetal poles. So that's a triplet gestation, but there's 2 of the babies in 1 sac. That is monoamniotic twin with a triplet pregnancy. Very awkward thing to describe. All right. So when we scan for multiples, we are comparing the 2 sides. Sometimes one side is much bigger than the other. One baby is much bigger than the other. That can be a sign of a problem. So finally, with this first trimester ultrasound is empty sac. There's a sac, but there's no baby. That is called blighted ovum, anembryonic pregnancy, and it's a form of missed miscarriage. What does missed miscarriage mean, or missed abortion? Baby died down the line, but the woman is not expelling it quickly. So it's a kind of missed miscarriage in which you cannot physically identify a fetal pole, and so it's described as blighted ovum. All right, now to the second trimester, second and third trimester ultrasound. I think that's what we have. So again, in the second trimester, where we do a scan, we're checking whether the baby is alive. And again, it is the heartbeat that is a critical factor. We're also checking, are there twins, triplets? Checking, is the baby growing well? That's what I mean by biometric measurements of the different baby parts to determine whether there's any cause for concern. Sometimes it's poor growth. Sometimes it's an abnormality of the fetus. E.g., very big head in hydrocephalus, very small head in microcephaly, or abnormal shapes, lemon shape of the skull, and all sorts of things, short limbs, inadequate bone formation. So all sorts of things can be abnormal. And if we know the normal, then we can be confident about the well-being of that pregnancy. Like I said, the heartbeat is a critical thing to determine that a baby is alive and also is well. Because the heartbeat is too slow, too fast, then of course we know that it can point to abnormalities either way. On the ultrasound, you can also often see baby movement. During a 5-minute ultrasound, most babies will move at least once. They move a limb. Even babies at 8 weeks make movements. They wobble like a grub. And these movements are reassuring a sign of health. There are different kinds of movements that can be seen by ultrasound. Gross body movements, movements of extremities, that's hands and legs flexing and extending, and then breathing movements, which is a good sign of fetal well-being. All right. So for the biometry part of it, that's what we use to track whether, like I said, whether the fetus is growing well. And so we can measure and say this is the gestational age and the size of the baby is compatible with it or not. There are 4 cardinal measurements that we use, which we have BPD, head circumference, abdominal circumference, and femur length. Now, to measure BPD, I think that's the most iconic measurement of fetal size or fetal growth or gestational age that there is. And as a matter of fact, in about 1956, the measurement of BPD was the first thing that was done when ultrasound was introduced into medical practice. It was BPD that was measured. You can imagine the technology of back then. And so it's relatively simple to measure because the skull is easy to identify, but we need to be very careful how we identify the section to make that measurement from. First of all, it needs to be symmetrical as much as possible. So as we have on that picture, the oval is symmetrical. Sometimes you have a shape that one side is wider than the other and there's asymmetry. And what helps you determine the asymmetry is that horizontal line at the mid portion, which is called the falx. As you can see in the image below, it's not always crisp like it's in the diagrams, crisp clear like it is in the diagram. But you usually will see it very clearly enough. And then that structure that is labeled CSP, I hope you're seeing these images very well. The CSP is called cavum septum pellucidum. Please don't mind all that Latin. It is easy to see that on every scan. And if you see it, you know you're at the right level. But also check that you have the thalami next to it. And check that you have a symmetry. These are the things that make you know that you're at the right level. And then if in doubt, you can take several measurements and get an average. Now, when you want to measure from one side to the other, the standard is if you start from outside, you should stop on the inside of the other side. That's called outer to inner. So if you start from the top, hopefully we can demonstrate it today with some of our volunteers that have come to help us. So let's not waste too much time on that. Abdominal circumference, again, very important. This is an important measurement of how the baby is laying on fat. And it's the most important measurement used by the system to calculate the estimated fetal weight. You also need to be careful about your landmarks. You need the spine, which is what we have on the right. That blue one, that's the umbilical vein, a section of the umbilical vein. And then the black oval at the bottom, that is the stomach, with the fluid that the baby has swallowed. Then femur length is the next measurement, very easy to find, but be careful because you might actually find humerus and think it is femur. When you're measuring the femur length, just measure what's called the diaphysis. It's got all those branches at the end that are not straight. We don't need those ones. They are going to cause falsehood in your measurement if you include that. Now, fetal anatomy, finally, is the other thing you're doing in the ultrasound of mid-trimester. But that is beyond the scope of this meeting. Because that thing that's called anomaly scan is a detailed session during which every organ that you can see on the scan, you zoom into it and check for any signs of abnormality. All right. Now, there are situations where scanning is difficult. Now, some of my images look beautiful and crisp and clear, and if you go to the internet, especially 3D ultrasounds, 4D scans. You see some nice images. People bring out the clearest and most beautiful images they ever acquired. It's not always like that. Just like in everything. In fact, a lot of the times you will struggle to see these things we are talking about clearly. And some of the factors that make a scan difficult I've outlined on this slide. If there's a lot of abdominal wall fat, then the pictures are not going to be clear because the sound needs to travel longer distance before getting to the structures you're examining. Now, for a patient with multiple scars on the abdomen, they kind of affect the way the sound is moving. I've found even scars on the uterus. Previous myomectomy creates scars that kind of scatter the sound, and your images aren't always as clear as they would have been before. Again, multiple gestation, especially if you have 3 babies or 4 in one uterus. Naturally, as you're trying to look from the front, somebody's back is there, somebody's leg is blocking, another baby's leg is obstructing that view. So multiple pregnancy can be challenging in scanning, but with a good diligent attitude, and by starting with the simpler cases, we can move on to the more difficult cases and then be able to conquer what needs to be conquered. Oligohydramnios. The water makes the sound clearer. When there's adequate lipo volume, the scan pictures are clearer. When there is fluid anywhere, the structures around that fluid are easier to see more clearly. So even things like ascites can make you see some organs better in the abdomen. So when there's oligohydramnios, these measurements can be more difficult. Again, when there are pelvic masses, especially fibroids, they're very common. If you have multiple fibroids, it can be an obstruction to seeing clearly what needs to be done. And you need to be careful because sometimes that introduces inaccuracies in the measurements or in the findings that you're seeing. Again, after surgeries, that's a particular situation where we face that a lot in this hospital, that after abdominal surgeries, a patient is manifesting certain symptoms and signs, and we feel that we need to do an ultrasound. The situation is a bit different. There's inflammation, there is tenderness. If it's after a cesarean section, there's a bulky uterus obstructing you. There are recent sutures casting white shadows all over the place. So sometimes there's a problem. And that makes it more technical and challenging. Again, full bladder, empty bladder. When you're doing an abdominal scan, usually you need a full bladder to make it better. Why? Because we always say that through fluid, the image is clearer. But the full bladder also moves the uterus upwards from the pelvis and more towards your probe. So that helps bring the structure that you're looking at closer to you. So that helps. Again, if you're doing a vaginal scan, it's the other way around. A full bladder becomes an obstacle because it can actually push the uterus away from the probe. And that makes it more difficult for you. That being said, sometimes you need to, if a patient is here for an abdominal scan with a full bladder, or what looks like a full bladder, sometimes you need to ask the patient to go and pee and come back and repeat your abdominal scan in order to make sure that, am I seeing the bladder? What I was seeing, was it bladder or is it a fluid collection somewhere? I hope you're with me on that. So these are some of the pitfalls we need to be careful about when we're performing a scan, so that we'll achieve the best results for the patients. This is my last slide. But after this slide, I have a short animation video that I'm hoping they can play for us. It's an animation video of obstetric ultrasound. Hopefully audiovisual is ready for us with it now. The knobs on the machine, that's what I'm trying to just point out. Sometimes it's very intimidating Because there's 1 million knobs, and we don't know what they're doing. We turn it to the left or to the right. Each machine has its own arrangement of things or the number of buttons that it has. And sometimes it can look very frightening, but most of the time, there are critical things that are uniform among them. At least they all have a power on, power off. Yeah? So you need to first of all turn your machine on, in case there's nobody else to turn it on for you. And you also need to be able to turn it off when you're done, because you don't want to leave the machine on through the night. We've been told how bad it is for the lifespan of the machine. Maybe again, beyond the power on, power off, the most important button is freeze. Because when you turn on a scan machine, the sound is being generated, it's functioning, it's looking for what image to catch. When you press the freeze, it stops doing that. And it just shows you the last image it got. So the consumption of power and the consumption of the lifespan of that probe is minimized when you freeze it. It's usually a very prominent button on most of our machines. So the freeze stops the video. And if you unfreeze it, then the video continues. That's the freeze. Then there's gain, which you can describe like a layman to mean brightness and more contrast, or darkness or less contrast. So we turn on, if you increase the gain, everything becomes brighter. So maximum gain, everything will turn white. Minimum gain, everything turns dark and unclear. So you need to find somewhere in between where the image is clear enough. And then related to gain is that DGT like equalizer buttons. And how that does is that the gain is like split layer by layer, so you can increase the gain at the superficial levels and decrease it at a deeper level, depending on how you're looking at the image. Then depth is something that is related to the type of probe and how deep the tissue you want to examine is. So if you're examining something and it seems to be too close to you, you can actually try and increase the depth, which takes the picture further so you can see more clearly what you're doing. Or reduce the depth and it brings it closer. So when you, I don't know, I hope I'm saying this incorrectly, but if you adjust the depth while you're scanning, it makes things more clear to you, depending on what you want. For instance, if let's say a post-operative period after abdominal surgery, there's a tender point in the abdomen and you think there might be something in the subcute or maybe the abdominal wall muscle. It's not as deep as inside the abdomen or the pelvis. So it's a very superficial one. I need to adjust your depth, reduce the depth so that the ultrasound can see the things that are closer to you and it makes it clearer. Whereas if you're looking for something far, for instance, you're doing a vaginal scan and the uterus is bulky, and then the fundal part of the uterus is so far. So when you increase the depth, then it brings the image closer to you, even though it gets smaller. These things are the important buttons on the machine. And then zoom.